We looked at the PK/PD of vancomycin. Now the next learning objective is determine a vancomycin loading dose for critically ill patients with serious MRSA infections. What is steady state? Steady state is the point at which the rate of drug administration is equal to the rate of drug elimination and the concentration of drug is constant. Now, steady state is based on the drug's half-life and it occurs after approximately 4 to 5 half-lives. Steady state is the most optimal time for obtaining vancomycin levels. So if you're gonna target trough, it's best to get it during steady state. Otherwise, you end up overdosing vancomycin because if you get the trough during this time, it's going to be subtherapeutic. On the other hand, before reaching steady state, there will be subtherapeutic levels of vancomycin. So we don't really want to decide our maintenance dose based on levels in the period of time before steady state, because if you decide the maintenance dose here, once the drug gets to steady state, you're gonna be overdosing vancomycin. So you want to get the levels during steady state. On the other hand, this raises an issue that before we get to steady state, we will actually be underdosing vancomycin. So one way to battle this is to actually give a loading dose. So the red graph shows you what happens without the loading dose. So it takes some time for the levels to rise up to steady state, which means that during the initial period, there will be subtherapeutic levels of the drug. By giving a loading dose, you quickly achieve a high dose. It will eliminate any subtherapeutic period of time, and then it will help you to get to that steady state faster without affecting the maintenance dose. So here's what the guidelines recommend for a loading dose. So it's only recommended in seriously ill patients. So patients with sepsis, meningitis, bacteremia, infective endocarditis, pneumonia, and osteomyelitis. And of course, only these infections if they're suspected to be due to MRSA infection. So if other organisms are causing this, these recommendations do not apply. But if MRSA is suspected in these infections, then a loading dose of 25 to 30 milligram per kilogram is recommended based on the total body weight dose. Now, because the loading dose are larger doses than the maintenance dose, it has the potential of causing reactions. So typically histamine reactions, so if that happens, we can use antihistamines in patients. We can also increase the infusion time. So if you infuse it over 2 hours, and I'll explain that more on the next slide. Loading doses are also helpful in patients who have creatine clearance less than 60, because the half-life is longer in these patients, so it actually takes longer for these patients to get steady state. So if someone has renal dysfunction, it will actually take a very long time for them to get to steady state, because steady state typically is 4 to 5 times the half-life. So if the half-life is longer in these patients, it takes even very longer to get to a steady state. So these patients will also benefit from a loading dose. So the first part is recommending loading dose for serious infections. This part is recommending for any infections in renal dysfunction. And they're saying do not exceed a single loading dose of 3,000 milligram or 3 gram because of those histamine related reactions. Now, we currently don't have clinical evidence that giving a loading dose actually makes a difference on mortality. It does make sense from a pharmacokinetic perspective that it can optimize the dosing in patients. So the 2011 IDSA guidelines for MRSA infections, they actually made a recommendation for seriously ill patients. And these are those who have sepsis, meningitis, bacteremia, infective endocarditis, pneumonia, and osteomyelitis. And for these patients, they recommended that a loading dose may be considered. So pay attention to the language. When they say may be considered, it means that it makes sense to do it. But, if you were to not do it, you're technically not denying the patient of life-saving intervention. Now, they recommended a dose of 25 to 30 milligram per kilo using total body weight. And because this is a large dose, you're going to end up with a large dose that puts the patient at risk of infusion-related reaction, specifically red man syndrome, which I will discuss shortly. So they do recommend to extend the infusion time to 2 hours, and also use antihistamines prophylactically in order to reduce the risk of having red man syndrome. And typically we use diphenhydramine 10 to 50 milligram, either IV or IM, to prevent red man syndrome. Now, in the new 2020 ASHP IDSA guidelines for therapeutic monitoring of vancomycin said that in critically ill patients with suspected or documented serious MRSA, and serious MRSA infection, basically the same types of infection that were listed above, and they actually give a wider range of dosing, so 20 to 35 milligram per kilo of total body weight, and they increase the range basically to allow better use of your judgment, so you can decide based on different characteristics of your patient which one would be more appropriate. And again, the languages can be considered, so it's not that you have to do it, but it makes sense to give this to patients with critical illness because they are at increased risk of mortality. Now, in obese patients, they do recommend a smaller dose of 20 to 25 milligram, and regardless of whether the patient is obese or not, the loading dose should not exceed 3000 milligram or 3 grams. And the most common infusion-related reaction is Redman syndrome. So Redman syndrome is histamine-mediated hypersensitivity. As you can see in this picture, it actually causes flushing, erythematous rash. It causes some pruritus, and sometimes mild to profound hypotension, including even cardiac arrest, which is not as common. And this can be avoided if you slow the infusion rate. Typically, if you reduce it to about 15 milligram per minute. And there are also standardized recommendations. So if you're, you don't want to infuse anything less than 1 hour. So the infusion time for vancomycin should be at least 1 hour. And then the higher the dose, you can actually prolong it. So for anything, if it's 500 milligram or 1000 milligram, you typically infuse over 1 hour. So a 500 milligram over 1 hour, it's about 8.3 milligram per minute, and then 1000 milligram infused over 1 hour is about 16.6 milligram per minute, which is almost around 15 milligram per minute. It's not too much higher than 15 milligram. So most people will tolerate 1000 milligram over 1 hour. If they start to have reaction, what we can do is to increase the infusion time to 90 minutes and potentially 2 hours. And then 1250 milligram is recommended to do a 90-minute infusion. The same with 1500 milligram. So again, 1250 over 1.5 hour translates into 13.8 milligram per minute. And 1500 milligram over 1.5 hour is about 16.6 milligram per minute. 1750 milligram is recommended to be infused over 2 hours, which is about 14.6 milligram per minute. And 2 grams are recommended to be infused over two hours, which is about 16.6 milligram per minute. Of course, you can infuse any of these even longer if the patient was not tolerating it. So for example, I have done 1000 milligram over 3 hours in patients before, just because they weren't tolerating it. And of course, you can also administer diphenhydramine to these patients to reduce the amount of this reaction. Most patients, however, will not experience it. So most patients actually tolerate vancomycin very well.